Hello, everyone, and welcome. Today, we're going to be focusing on Chapter 6, all about disorders of trauma and stress. So, when we think about stress, something for us to think about is that the stress is something that can impact us at any point in our life. And typically, we're going to find that with many components of stress, that it's going to impact us physically, emotionally, psychologically, and in other areas of our dimension. What actually leads us to experience stress is what's called a stressor. This is an event that will create a demand on our mind or our body or both. And typically, with a stressor, it can cause fear when it's viewed as threatening. Fear is a package of responses, again, that are physical, emotional, and cognitive. The stress response is the reaction to the stressor or the reaction to the event that's creating this demand that impacts us physically, emotionally, and cognitively. There are also some extraordinary stress and trauma experiences that can be a one-time event or can happen on an ongoing basis that certainly plays a role in how someone may be diagnosed with a stress-related disorder. People who experience a large number of stressful events are particularly vulnerable to the onset of things like anxiety or other psychological disorders. When we think about stress and psychological disorders, you're going to find that the ones that we're going to be focusing on are acute stress disorder or PTSD, post-traumatic stress disorder. The DSM-5 actually lists these as trauma and stressor-related disorders, whereas previously they were placed under anxiety. When we look at stress and physical or psychophysiological disorders, the DSM will list these under psychological factors affecting mental condition. Let's take a second to talk about stress and arousal. So we're going to look at the fight or flight response. When we think about the fight or flight response, these are features of arousal and fear that are set in the hypothalamus. And there are two systems that are activated. We have the autonomic nervous system, or ANS, and the endocrine system. So when we look at the ANS, this is an extensive network of nerve fibers that connect to the central nervous system, or CNS. Remember, that's the brain and spinal cord. And this network spans from the central nervous system to all other organs of the body. The endocrine system is a network of glands throughout the body that release different hormones, not only neurotransmitters, but also things like sex hormones. So what we see here is the autonomic nervous system. When the sympathetic division of the autonomic nervous system is activated, it stimulates some organs and inhibits others, as you can see on the left-hand side of your screen. The result is a state of general arousal. In contrast, activation of the parasympathetic division leads to an overall calming effect, as you can see on the right-hand side of your screen. When we think about the sympathetic nervous system, these are the nerve fibers of the autonomic nervous system that quicken the heartbeat and produce other changes experienced as arousal, including relaxing the bronchi, dilating pupils, stimulating the release of glucose for energy, relaxing the bladder, and stimulating the secretion of epinephrine and norepinephrine. The parasympathetic nervous system are the nerve fibers of the autonomic nervous system that help return bodily processes to its baseline. So that's going to do things like contract the bladder, stimulate the gallbladder, slow the heartbeat, and contract pupils and constrict the bronchi. I encourage you to pause to take a look at figure 6.1 to see what happens during the sympathetic and parasympathetic stimulation of the autonomic nervous system, and continue on when you're ready. There are two pathways by which the autonomic nervous system and the endocrine system produce arousal and fear reactions. Again, that's the sympathetic nervous system pathway. And we also have the hypothalamic pituitary adrenal pathway. When we face a dangerous situation, the hypothalamus first excites the sympathetic nervous system, which stimulates key organs either directly or indirectly. When the perceived danger passes, the parasympathetic nervous system returns the body to normal processes or its baseline processing. The reaction on display in these two pathways are collectively referred to as the fight or flight response. Each person has a particular pattern of autonomic and endocrine functioning and, therefore, a particular way of experiencing arousal and fear. In the hypothalamic pituitary adrenal pathway, the hypothalamus will signal the pituitary gland, as you can see, which is also in the brain, and this stimulates the adrenal cortex which rest above your kidneys, to release corticosteroids or stress hormones into the bloodstream. When we're confronted by a stressor, our bodies produce arousal through two pathways. In one pathway, the hypothalamus sends a message to the sympathetic nervous system, which then activates key body organs, either directly or by causing the adrenal medulla to release epinephrine and norepinephrine into the bloodstream. The other pathway, the hypothalamus, sends a message to the pituitary gland, which then signals the adrenal cortex to release corticosteroids or stress hormones into the bloodstream. Now that we understand this, let's look at acute and post-traumatic stress disorders. During and immediately after trauma, we may temporarily experience levels of arousal, anxiety, and depression. For some, symptoms persist well after the trauma. These people may be suffering from acute stress disorder or post-traumatic stress disorder. When we think about the precipitating event, this usually involves actual or threatened serious injury to self or others. The situation that causes these disorders would be traumatic to anyone, unlike other anxiety disorders. So, the difference between acute stress disorder and post traumatic stress disorder is that acute stress disorder, where symptoms begin within 4 weeks of the event and last for typically less than a month. Post traumatic stress disorder are where symptoms may begin either shortly after the event or months or even years afterwards. And typically, these things last for more than a month. As many as 80% of all cases of acute stress disorder will develop into post traumatic stress disorder. So, aside from the differences in onset and duration, there are symptoms of acute stress disorders and PTSD that are almost identical. And these things include increased arousal, increased anxiety, and increased guilt, re experiencing the traumatic event through things like flashbacks and nightmares, avoidance of people, places, things, and situations, and finally, reduced responsiveness and even dissociation, where someone feels that they are outside of themselves looking at themselves. So, the checklist to be diagnosed with acute or post traumatic stress disorders will include that a person is exposed to a traumatic event, death or threatened death, severe injury, or sexual violation are just some examples. And a person must experience at least one of the following intrusive symptoms. This is repeated, uncontrolled, and distressing memories, again through flashbacks or nightmares, repeated and upsetting trauma linked dreams, dissociative experiences, again like flashbacks, significant upset when exposed to trauma linked cues, and pronounced physical reactions when reminded of the events. The person continually avoids trauma linked stimuli. The person experiences negative changes in trauma linked cognitions and moods, such as being unable to remember key features of the events or experiencing repeated negative emotions like anger, frustration, irritation, or sadness. The person displays conspicuous changes in arousal or reactivity, such as excessive alertness, extreme startle responses, or sleep disturbances, and that can be falling asleep and or staying asleep. And the person experiences significant distress or impairment with symptoms lasting more than a month. Something to think about when we look at stress disorders, whether it's acute or post traumatic, is that it can occur at any age and affects all aspects of life. Approximately 7 to 9% of people in the United States are affected sometime during their lifetime, and it affects at least 3.5% of people in the United States annually. It's more common in women in a 2-to-1 ratio and people with lower incomes. 2/3 of affected people will seek treatment at some point in their life. And it's more likely to be caused by some events that could be combat, disasters, abuse, or victimization. After trauma, approximately 20% of women and 8% of men will develop either acute or post traumatic stress disorders. What are some triggers? Well, the number one can be combat. When we think about combat and stress disorders, this can be known as shell shock or combat fatigue. Post Vietnam War clinicians discovered that soldiers also experience psychological distress after combat. As many as 29% of Vietnam combat veterans suffered acute or post traumatic stress disorders. An additional 22% had some stress symptoms. Some 10% are still experiencing problems. A pattern is currently unfolding among 2.7 million veterans of those who are part of OEF, OIF, OND, or post 9/11. When we think about acute or post-traumatic stress disorders, it may also follow things like disasters or accidents. Types of disasters include things like earthquakes, floods, tornadoes, fires, airplane crashes, and serious car accidents. Because they occur more often, civilian traumas have been implicated in stress disorders at least 10 times as often as combat veterans. When we look at victimization and stress disorders, people who have been abused or victimized often experience lingering stress symptoms. Researchers suggest that more than 1/3 of all victims of physical or sexual assault develop post-traumatic stress disorder. And then we also have terrorism and torture. The experience of terrorism or the threat of terrorism often leads to post-traumatic stress symptoms, as does the experience of torture. So, why do people develop acute and post-traumatic stress disorders? Well, it could be based on biological factors, childhood experiences, personal styles, social support systems or lack thereof, and finally, the severity and the nature of the traumas. So, we're going to be looking at each one of these individually. So, why do people develop acute and post traumatic stress disorder? Well, let's first start with biological factors. There's some research that suggests that normal neurotransmitter and hormone activity may play a role in this, especially if there's abnormal release, either too much or too little, of norepinephrine and cortisol. Once a stress disorder sets in, further biochemical arousal and damage may also occur, especially in the hippocampus and the amygdala. There may also be a biological or genetic predisposition to such reactions, especially if your parents or great grandparents, or excuse me, if your parents, grandparents, and or great grandparents also had suffered from some type of stress disorder. Researchers have also found that certain childhood experiences increase the risk for later stress disorders. This can include things like an impoverished childhood, psychological disorders in the family, the experience of assault, abuse, or catastrophic events at an early age, and being younger than 10 years old when parents were separated or divorced, especially if they have an inability to co parent effectively. When we look at personal styles, some studies suggest that people with certain personalities, attitudes, and coping styles are particularly likely to develop stress disorders. These things include things like pre-existing high anxiety and a negative worldview. A set of positive attitudes, which is called resiliency or hardiness, can be a protective factor against developing stress disorders. We also need to take a look at social support systems. Unfortunately, weak family ties and weak social support systems can lead someone to experience acute or post traumatic stress disorders because they don't have the people to rely on to help encourage them, or that these experiences are so bad with their family and social supports that it actually causes further harm or re-victimization to occur. We also need to look at the severity and nature of the trauma. The more severe or prolonged the trauma, the more likely that someone is to develop post-traumatic stress disorder. The more direct exposure to the trauma, the more likely someone is to develop acute or post-traumatic stress disorders. If the trauma was intentionally inflicted, or if there were things like mutilation, severe physical injury, or sexual assault, the likelihood of developing a stress disorder is much higher. We also need to look at developmental psychopathology, the timing of the stressors and traumas over the developmental course, and inherited or acquired biological predisposition for overactivity in the brain body stress pathways and dysfunction in the brain circuit can certainly play a role, simply because as the person is not only physically developing, they are also cognitively developing. And if their body is being exposed to certain events or ongoing events, or even a singular event that can cause any kind of change in the brain body stress pathway or in the brain stress circuit, their baseline is going to be markedly different than that of someone who has developed further in life, or someone at the same developmental level who has not experienced a singular or ongoing traumatic event. We also need to take a look at the principles of multifinality and equifinality. When we think about equifinality, this is the understanding that many different pathways or risk factors may result in the same outcome. Multifinality is the understanding that specific risk factors may result in a magnitude of developmental outcomes. So, in looking at these and connecting them to not only the cognitive development, but also to the brain body development, it would make sense because there are people who are going to experience different traumas in different ways, depending on things like their family and social supports, their coping mechanisms, the developmental age or the cognitive age at development, the types of traumas, the timings of the traumas. All of these things play a role in how someone will experience a traumatic event. So there are some people where, again, under multifinality, that there could be a specific risk factor that can result in different developmental outcomes. This would be a traumatic event. When we think of equifinality, this is where there are many different pathways or risk factors that can result in the same outcome. So many people may share similar, that many people may have experienced a similar experience or the same experience, but they have different outcomes, that some people are going to be more resilient or more hardy, whereas others are not. And that's where all of the other perspectives come in to connect to how people will respond to these stressors or traumatic events. So, how do clinicians treat acute and post-traumatic stress disorder? So, it's important to note that about half of all cases of PTSD will improve within 6 months, and the remainder may persist for many years. But there are treatment procedures that can vary depending on the type of trauma, which we're going to talk more about in chapters 8 and 15. But the general goals of treatment are going to be the end to end lingering stress reactions, gain perspective on painful experiences while reducing the emotional reaction to these painful experiences, and return to constructive living. When we look at combat veterans, there's typically going to be a combination of methodologies for treatment that will come into play. The first is the use of antidepressant drugs. There are many combat veterans who will take either on a short term or even a longer term basis will take antidepressant drugs as they're going through therapy. Then we have cognitive behavioral therapy, where they will do things like cognitive processing, mindfulness based, or exposure techniques, specifically prolonged exposure. And finally, they'll also try EMDR, or eye movement desensitization and reprocessing. Many, because even though the traumatic event impacted them, it also impacts their system. So many combat veterans can also benefit from couples and or family therapy. Many, in addition to taking some type of medication and doing individual cognitive behavioral therapy, may also be a part of group therapy. Exposure-based treatment is the best intervention for people with post-traumatic stress disorder. Exposure-based therapy is regarded within veteran research as the single most helpful intervention. So this can include things like in vivo exposure, which is where you slowly increase, not only do you increase the amount of time or the amount with in vivo exposure. Sorry, I'm getting ahead of myself. I apologize. But with in vivo exposure, this is where you are going to continuously expose the person to an event through retelling stories. And then those stories turn into images, and then those images turn into similar events. Today, the number one way is through virtual reality. In virtual reality therapy, clients use wraparound goggles and joysticks to navigate their way through a computer-generated military convoy, battle, or bomb attack in a landscape that looks like one that they've experienced typically in Iraq or Afghanistan. And again, with couples or family therapy, this can be helpful for not only the individual, but also for the partner and or children. In group therapy, they can do things that are based on either a similar event, like a combat related issue in Iraq or Iran or Afghanistan, or based on a actual therapy method like cognitive behavioral therapy. They also have what are called rap groups, and rap groups are where they have the ability to literally use music in conjunction with therapy to support them. And by using this method, it can be really helpful to utilize the music, adding in their own language, and then using different beats to help convey what is happening for them. And again, this can also be supported not only in group therapy, but then again, supported in individual counseling. There's also psychological debriefing, which may also be called critical incident stress debriefing. And this is a crisis intervention in which people who have been impacted by trauma talk extensively about their feelings and reactions within days of the critical event from happening. At this time, there is not as much support in research to show that this can be beneficial for combat veterans, but in other events like after 9/11 or other natural disasters, it can be helpful. Now let's move on to dissociative disorders. The dissociative disorders are a group of disorders that are triggered by a traumatic event. And when such changes in memory lack a clear physical cause, they can be called dissociative disorders. The key to our identity, the sense of who we are and where we fit in our environment, is our memory. Our recall of past experiences helps us to react to present events and guides us, I should say, in making decisions about our future. People sometimes experience a major disruption of their memory. They may not remember new information or old information. Dissociative symptoms are often found in cases of acute or post-traumatic stress disorder. When such symptoms occur as part of a stress disorder, they don't necessarily indicate a dissociative disorder or a pattern in which dissociative symptoms dominate. And there are different kinds of dissociative disorders, which include dissociative amnesia, dissociative fuse, dissociative identity disorder, and this used to be called multiple personality disorder. Under DID, or dissociative identity disorder, many of them have subpersonalities and alternate personalities, which we're going to be talking about. In dissociative amnesia, this is the inability to recall important information, usually of an upsetting nature about someone's life. So the memory loss is much more extensive than normal forgetting and is not caused by other physical or neurocognitive factors. Often the amnesia episode is directly triggered by a specific upsetting event. So part of the checklist for dissociative amnesia is that, again, the person can't recall important life-related information. It can lead to significant distress or impairment, and the symptoms aren't caused by a substance or medical condition. With dissociative identity disorder, the person experiences a disruption in their identity and is reflected by at least two separate personality states or experiences of possession. So these could be subalters. The person repeatedly experiences memory gaps regarding daily events, key personal information, and traumatic events. It also must lead to significant distress or impairment, and the symptoms aren't caused by a substance or medical condition. When we think about the difference between dissociative amnesia and dissociative identity disorder, the main things to think about is that with dissociative identity disorder, they typically have subalters or other personalities. Whereas with dissociative amnesia, they're going to have a difficult time recalling this important information. When we think about the memory loss, the amnesia can be localized, selective, or generalized. So if it's localized, they're going to be unable to recall a specific event or events for a specific period of time. So this may be where someone may forget the months or years of being abused as a child or the days spent in intense combat. So the amnesia may not manifest for a period of time after the trauma, but the forgotten time period, which can range from minutes to decades, is clearly marked. When we look at selective amnesia, this is where you forget only some of the events during a certain period of time. And it's not uncommon for people to have both localized and selective amnesia. In generalized amnesia, patients forget their identity and their life history, like who they are, where they went, who they spoke with, and what they did. So when we think about this, generalized dissociative amnesia is very rare, and it's more common among combat veterans, people who've been sexually assaulted, and people who experience extreme stress or conflict. And the onset is typically sudden. It doesn't lead into it. There can also be systematized amnesia. And in this, patients forget information about a specific category, like all information about a particular person or about a family member. And with continuous amnesia, patients forget each new event as it occurs. And again, with dissociative identity disorder, we are thinking about someone who may have some of these aspects, but they actually have created, as part of a coping mechanism, these subalters that can help them. And here, I just talked about dissociative amnesia. So I encourage you to take a minute to take a look at this and then continue on when you're ready. Now we're looking at dissociative fuse. And when we think about dissociative fuse, we are thinking about this extreme version of dissociative amnesia. So this is a really rare psychiatric disorder that's characterized by these reversible aspects of amnesia for personal identity, including memories, personality, and other characteristics of someone's personality. For some, the fuse is going to be brief. It's a matter of hours or days and end suddenly. For others, the fuse is going to be more severe. People may travel far from home, take a new name, establish new relationships, and even enter a new line of work. Some may even display new personality characteristics. When people are found before their fuse is ended, therapists may find it necessary to continually remind them of their own identity. The majority of people regain almost all of their memories and never have a reoccurrence. So, when we think about dissociative amnesia or fuse, something for us to think about is, when it comes to a child, is this a repressed childhood memory? Is this false memory syndrome? Is this part of dissociation? It's for us to think about and explore further when we meet. Now let's talk about dissociative identity disorder. Again, it was formerly known as multiple personality disorder. For people who have this, they will have two or more distinct personalities or subpersonalities that may develop. At any given time, one of the subpersonalities will dominate the person's functioning. Usually one of the subpersonalities, called the primary or host personality or host alter or primary alter, appears more than the others. The transition from one subpersonality or subalter to the next, which is called switching, is usually sudden and may be dramatic. Most cases are first diagnosed in late adolescence or early adulthood. Symptoms generally begin in childhood after episodes of abuse, and the typical onset is before the age of 5. Women are diagnosed at a 3-to-1 ratio over men. So how do subpersonalities or subalters interact? Well, they can have 3 types of relationships. Mutually amnesic relationships, or subpersonalities have no awareness of one another. Mutually cognizant patterns is where each subpersonality is well aware of the rest. And one-way amnesic relationships are the most common pattern, where some personalities are aware of others, but the awareness is not mutual. Those who are aware are what are called the co-conscious subpersonalities, and these are the quiet observers. The average number of subpersonalities is now thought to be 15 for women and 8 for men, often and when they appear is in groups of 2 or 3. The most well-known person to be documented to have subalters and subpersonalities is Sybil, and we'll be talking about her more when we get together. So there are some identifying features when it comes to subpersonalities, and they're going to differ in features such as age, sex, race, and family history. They may also have different abilities and preferences. Although information is not usually affected by dissociative amnesia or fuse, in DID, encyclopedic information can be disturbed. It's not uncommon for different subpersonalities to have different abilities, including being able to drive, speak a foreign language, or play an instrument. When we look at physiological responses, researchers have discovered that subpersonalities may have physiological differences, such as differences in autonomic nervous system activity, blood pressure levels, and even allergies. So how common is dissociative identity disorder? Traditionally, DID was believed to be rare, but the number of people diagnosed with DID has increased. There may be two factors that can account for this increase. Number one is diagnostic procedures have become more accurate. And number two, there's a growing number of clinicians who believe that the disorder does exist and are willing to diagnose it, which is a change because there are still many clinicians who believe that DID does not exist. Some researchers argue that many or all cases are what are called iatrogenic, that is, that they are unintentionally produced by practitioners. These arguments are supported by the fact that many DID cases first come to attention only after a person is already in treatment. And this isn't true of all cases, however, but for many it can be. When we think about how do theorists explain dissociative amnesia and dissociative identity disorder, there's a variety of theories that have been proposed to explain dissociative related disorders. Older explanations have not received much investigation, but newer viewpoints, which typically look at cognitive, behavioral, and biological principles, are capturing the interest of clinical scientists. And as a result, there are more research studies being conducted more often than ever. When we look at dissociative disorders from a psychodynamic perspective, they believe that dissociative disorders are caused by repression. People fight off anxiety by unconsciously perceiving painful memories, thoughts, and impulses from actually reaching full awareness. Dissociative amnesia and fuse are single episodes of massive repression, and dissociative identity disorder results from a lifetime of excessive repression, which is motivated by the very traumatic childhood events in which they have been affected by. Most of the support for the psychodynamic model is drawn from case histories, which report brutal childhood experiences, including physical, emotional, and sexual abuse. Yet only a small fraction of abused children will develop this disorder. In the cognitive behavioral perspective, dissociation grows from the normal memory processes and is a response learned through operant conditioning. And many behaviorists will also rely largely on case histories to support their view of dissociative disorders, saying that these explanations fail to explain all aspects of dissociative disorders. Momentarily forgetting of trauma leads to a drop in anxiety, which increases the likelihood of future forgetting. So, like psychodynamic theorists, behaviorists will see dissociation as escape behavior, part of that operant conditioning. We also can look at state-dependent learning. So this is where learning becomes associated with the conditions under which it occurred so that it is best remembered under the same conditions. People who are prone to develop dissociative disorders have state-to-memory links that are usually rigid and narrow. Each thought, memory, and skill is tied exclusively to a particular state of arousal so that a person recalls a given event only when they experience an arousal state almost identical to that state in which the first memory was acquired. So when they are remembering certain things, then they may have similar reactions. But if they repress it and avoid it, then they're not going to be experiencing it as much. There's also self-hypnosis. This is the parallel between hypnotic amnesia and dissociative disorders. Although hypnosis can help people remember events that occurred and were forgotten years ago, it can also help people forget facts, events, and their own personal identity. People with dissociative amnesia and fuse often recover on their own. Only sometimes do their memory problems linger and require treatment. People with DID usually require treatment to regain their lost memories and develop an integrated personality. Treatment for dissociative amnesia and fuse tends to be more successful than treatment for dissociative identity disorder. Psychodynamic therapists will typically guide patients to search their unconscious and bring forgotten experiences into the conscious. In hypnotic therapy, patients are hypnotized and guided to recall forgotten events. In drug therapy, which often can be called things like utilizing truth serums, intravenous injections of barbiturates are sometimes used to help the patient regain these lost memories. And the truth serums are the key to the drug success. The barbiturates, has an ability to calm people and free their inhibitions. Unlike victims of dissociative amnesia or fugue, people with dissociative identity disorder do not typically recover without treatment. Treatment for dissociative identity disorder is complex and difficult and is on a case by case basis based on the ability to understand the primary alter and subalters and understand when they're switching. Unlike victims of dissociative amnesia, people with dissociative identity disorder don't typically recover without treatment. Therapists usually try to help clients recognize the nature of their disorder, and that can be through bonding with the primary personality and things like hypnosis, group, and family therapy. Therapists will also help to recover the gaps in their memory by using things like psychodynamic therapy, hypnotherapy, cognitive behavioral therapy, and even drug treatment. And therapists will also help to integrate the subpersonalities into one functional personalities. In order for this to be successful, fusion, ongoing therapy, needs to be maintained in order to complete that personality. The DSM-5 categorizes depersonalization and derealization disorder as a dissociative disorder, but is not one characterized by the memory difficulties found in other dissociative disorders. The central symptom of depersonalization and derealization disorder is persistent and recurrent episodes of depersonalization and derealization. Depersonalization experiences themselves don't indicate a depersonalization disorder. So transient depersonalization recalls are very common. The symptoms of a depersonalization disorder are persistent or recurrent issues that cause considerable distress and interfere with social relationships and even job performance. I hope that this was helpful for you. As always, if you have any questions, comments, or concerns, please don't hesitate to reach out to me. Also, don't forget, in the description box below is this week's extra credit video. All you need to do is watch the video, add your response in the comments section, take a screenshot, and upload it to Canvas for up to 1 point added to your final grade. Also, it's due by Sunday at 11:59 p.m. Don't forget. Until next time, I hope that you have a great one and be well.